Hi, everyone. I'm Kelsey, and I'm going to be one of the speakers today, along with my colleague Yolanda Hinton, who's a PA, and my colleague Lisa Najera, who is a women's health nurse practitioner. And we're just going to be talking a little bit about your postpartum pelvic floor and all of the changes that can happen after you deliver a baby. So, one of the first questions I always get asked when I tell people what I do is, what is the pelvic floor? And what the pelvic floor is it's basically a group of muscles that sits at the bottom of the pelvis. As you can see in the picture here, it's kind of like a hammock. And what it does is it supports the pelvic organs, which include the uterus, the bladder, and the rectum. And as you can imagine, going through those muscles are the urethra, where urine comes out of, the vagina, as well as the rectum. And therefore, these muscles contribute a lot to your bladder control as well as your bowel control. So, what happens when you deliver a baby? It's actually really incredible. Your pelvic floor muscles can stretch up to 200% of their normal length when you deliver, which is even more incredible when you consider that the average muscle can only stretch maybe about 100 to 150% of its length. So, of course, when that happens, there is a risk of those muscles tearing. And sometimes those muscle tears are very small or superficial, and other times they can be more deep. And there's something that you can see after you deliver baby, and they may need to put sutures in to kind of bring all those muscles back together. So after you deliver, of course, we start this whole process of your pelvic floor healing. And it takes about 1 to 2 full years postpartum for your pelvic floor to fully remodel to where it's going to be until you deliver again or for the rest of your life. And during that process, you can have some different things kind of come up. So, for example, your muscles can be a little bit more weak, or sometimes they respond by holding a lot of tension and becoming more tight. And another important thing to mention is that while you breastfeed or when you're pumping, the estrogen levels in your bodies go down. And what can sometimes happen is it can slow down some of the healing of the pelvic floor because those estrogen receptors or the tissues in the vagina are very responsive to estrogen levels.
So I have urinary incontinence. This is another thing that we can commonly see in that postpartum period. And it's actually probably one of the most common complaints we get. The definition of urinary incontinence is the involuntary or accidental loss of urine. It's very common in the postpartum period, and up to 50% of women can experience this. So know that if you are going through this, you are not alone, and there's a lot of women out there who are as well. There are two very different types of incontinence that we see in clinic. We see that urge incontinence and that stress incontinence. With stress incontinence, this is defined as the loss of urine with any physical activity or movement, such as coughing, laughing, sneezing, or even exercise. What happens with these activities is it puts pressure on the bladder. And because the muscles surrounding the urethra have become weakened, it allows that urine to leak out. The muscles surrounding the urethra can become weakened for a variety of reasons, including childbirth, aging, chronic coughing, hormonal changes, and even obesity. The other type of incontinence that we see a lot of is what we call urge incontinence, or otherwise known as overactive bladder. With this type of incontinence, we get that sudden, intense urge to urinate, and then again, you will leak urine. This leakage is caused by the overactive muscles that are surrounding the bladder. They contract. And again, because those muscles surrounding the urethra are weak, it does allow that urine to leak out. You can go next.
So the next thing that I want to review is a more general topic, which is pelvic pressure, which can, of course, be very common after a delivery. And I define this as feeling a sense of heaviness in like the lower abdomen or in the pelvis. And there's three really common causes for this. Lisa's already briefly touched on one of those, which is the weakness of the muscles. Because you can imagine if those muscles are weak and they're not supporting things as well, then it'll feel like there's more pressure pushing down. There is a condition as well that we'll go into a little bit more in a second called prolapse, where the pelvic organs themselves are like physically dropping down inside of the vagina. And you can also get pressure with something called a high tone pelvic floor, which is where you're holding more tension in those muscles. So, like I said, the next thing that I was planning to touch on is pelvic organ prolapse. And we define that as the descent of one or more pelvic organs into the vagina. So, a lot of people ask, what can drop in the vagina? And really, the most common things that we see is the bladder on the front wall of the vagina, the rectum on the back wall of the vagina, or kind of coming from the top, the uterus can drop as well. And even people that have hysterectomies can have the dropping of the top of the vagina. And most of the time, like I mentioned, the early stages of prolapse present as a sensation of pressure or heaviness. And a lot of times it's worse towards the end of the day after you've been on your feet for a little bit longer. And it may resolve with rest or after you've been laying down. As prolapse progresses, some people can actually feel almost like there's a bulge coming out of the vagina. And sometimes people describe it as like a golf ball or something soft at the vaginal opening. And there's a ton of risk factors for prolapse. Delivering vaginally is, of course, one risk factor, but people that struggle with constipation are also at a really high risk. And also people that do a lot of high impact activities. So a lot of running or jumping, that puts stress on the pelvic floor. And also people that do a lot of heavy lifting. Another thing that I didn't put on this slide specifically, but we do think that there's a genetic risk factor as well. So your connective tissues and how they respond to stress over time may be very different than another person's connective tissues. So overall, after a delivery, we really focus on conservative management of prolapse. Even though it is a little bit scary to think about things dropping in the vagina, it's not an emergent situation the vast majority of the time. So if you didn't necessarily want to do anything, you can just watch the prolapse, which is expectant management. But most of the time when people come to us, they're looking for something beyond that. So one thing that you can do is pelvic floor physical therapy, which Lisa will get into a little bit later in the presentation. And we can also fit you for this device. It's called a pessary. And basically what it is it's a little silicone ring that you can actually fold and put inside of your vagina. And what it does is it acts a little bit like a sports bra for the vagina. So it just holds everything up. And when everything is elevated, then you're not feeling that heaviness in your pelvis. And there are surgical options, but the vast majority of the time we wait until you are done delivering kiddos. And you also have to be a certain amount of time postpartum before it's something that we would consider for treatment. The next thing that I wanted to mention is, of course, the high tone pelvic floor, which we define as tension or a spasticity in the pelvic floor muscles at rest. So this isn't when you are intentionally contracting the muscles. It's almost like those muscles are just tense without you meaning for them to be tense. And sometimes this also presents as pelvic pressure, which is why it's important to get evaluated when you have these symptoms, because there's so many different things that can cause that symptom. Sometimes it also makes it very difficult to empty your rectum because those muscles need to relax for you to be able to empty your rectum. And believe it or not, it can also impact your urinary symptoms because all of those nerves are so close together. When those muscles are tight, tight, tight all the time, it almost tells your bladder that it needs to go more often. And it can present as like a sense of urgency where you need to go to the bathroom, almost like it hits you out of nowhere and you have to go. And another really common symptom of this is pain with intercourse as well. So, in terms of treatments, there is actually a whole lot of treatment that we can do for a high tone pelvic floor. Physical therapy is really the first line for most patients. And physical therapists use some of the tools that I have put on this slide. Dilators that may help kind of stretch those muscles out, pelvic floor wands that help you sort of massage out those muscles, almost like you're releasing like a knot in your shoulder, but just in the pelvic floor. And there are also like suppositories, like medications that you can put inside of the vagina that help those muscles relax.
So another thing that comes along with, as we've talked about urinary incontinence and the pelvic pressure, as Kelsey mentioned briefly prior, is constipation. So constipation can cause a heaviness within the pelvic floor and can also worsen those bladder symptoms of urinary incontinence like Lisa was discussing. So the definition of constipation is less than 3 bowel movements per week, and stools that are hard, dry, and or lumpy. And our goal when we talk to all of our patients is for you to have one soft but formed bowel movement every 1 to 2 days. So a question that I always ask patients when they come in is, what does your poop look like? And so I typically bring up this chart and we kind of talk through exactly, what does your typical bowel movement look like? And as you can see here, type 3 and type 4 are normal. So smooth, on the smooth side, maybe some lumps, but definitely not these hard pebbles or a mushy consistency. And then when we talk about constipation treatments, so treatments for constipation, we include several things. So fiber supplementation can be a big key. So fiber adds bulk to the stool for easier passage of the stools. So if you're seeing stool that are more on the loose side, we often talk about adding in that fiber. And the goal for adults is 25 to 30 grams of fiber a day. And you can achieve that by a combination of high fiber foods, such as avocados, beans, lentils, oats, berries, or supplements like Metamucil and Benefiber. And our recommendation is always to increase your fiber consumption slowly to help reduce any bloating that you may have with that fiber increase. And the other thing that we talk to patients about often are stool softeners or laxatives that can be used for patients that have harder stools, are having difficulty emptying their rectum, or having bowel movements. And there are lots of different types of medications when you're standing in that aisle at the store, but we'll go through them here. Our first is osmotic laxatives. And this is the one that we often and mostly recommend to patients. So this is the most gentle form of a laxative that you can use. And how it works is it helps to bring water to the stool to help smooth it out, so that you're having smoother bowel movement, so you're not having to sit on the toilet and strain to have a bowel movement, which, as Kelsey talked about, can increase your risk for prolapse. And examples of those are magnesium supplements and Miralax. There are emollient laxatives like Colace, which help to bring water and fat to the stool to penetrate it, to soften it. There are stimulant laxatives, which I think a lot of people use. They're a bit harsher. We don't typically recommend those to patients, but how those work is they cause bowel contractions, so they help to kind of move the stool out and kind of push on it. And Senna and Biscoidal are a couple of the options that we hear frequently. The other option are suppositories, so treatments that are inserted into the rectum to help stimulate a bowel movement as well. And then our other big treatment option for constipation is pelvic floor physical therapy. So as Kelsey discussed, the muscles in the pelvic floor can weaken after delivery. And with that weakening of the muscles, the body's not helping you to have those bowel movements. And so pelvic floor physical therapy, as they work with you on strengthening the pelvic floor, can also help to improve constipation symptoms. And then our other treatment is a footstool, or more commonly known as the squatty potty. So to help improve your toilet posture, you could put your feet up on a stool. And as you can see here, when your feet are elevated and your knees are above the level of your toilet, the muscles in the pelvic floor relax, and hopefully for healthier elimination of stool. So as we have evolved, we used to squat to have a bowel movement. And as we have evolved, we've gone to toilets. We're sitting either at a 90-degree angle, or for many of, we also see a lot of elderly patients, so they have higher toilets. And so those muscles in the pelvic floor are very tight and are not helping them to have those bowel movements.
So as Kelsey and Yolanda mentioned, there is this lovely treatment called pelvic floor physical therapy. It is a specialized type of physical therapy that focuses on the muscles of the pelvic floor. It does tend to require special certification. And again, it focuses on strengthening and rehabilitating those muscles. These muscles, as Kelsey previously mentioned, support the bladder, the uterus, the rectum, and the bowel. And it really is used to treat a lot of conditions, including urinary incontinence, pelvic organ prolapse, that pain with intercourse, bowel issues, postpartum recovery, as well as those tight pelvic floor muscles that Kelsey previously talked about. It's more than just Kegels. So what I like to tell my patients is it's like Kegels on steroids, because the PT will assess your pelvic floor squeeze, but they also assess all the muscles in the pelvic floor. And as you can see from the picture, there's a lot, and give you exercise recommendations based off what they're seeing so that you can really see that symptom improvement. It can be started as soon as 6 weeks postpartum, so pretty quickly after delivery. And it really is the gold standard in initially treating those pelvic floor issues. It does involve an internal assessment. So they will place a gloved hand into the vagina and assess your pelvic floor strength, coordination, as well as any function. It can also help with desensitization as well as resensitization. So as we all know, childbirth changes a lot of things in our pelvic floor. And one of those is that sensation in the vagina. So what pelvic floor physical therapy does is it can work on calming down some of those nerves and muscles, which can decrease discomfort. But it can also stimulate those nerves so that if there wasn't any internal damage done during delivery, it can help with that as well. Another thing that we see sometimes is people feel like they plateau in physical therapy. So a tool that our PTs use a lot is something called eStim, and that stands for electrical stimulation. And with electrical stimulation, it sends impulses to those muscles and those nerves to, again, help with muscle coordination, with pain, incontinence, and a lot of those pelvic floor issues. So I thought it might be fun to do a little bit of an interactive part to this presentation. So I'm going to go over how to properly do a Kegel squeeze. So most of us have been taught that it's just kind of a quick squeeze into the vagina, but there really is a proper way to do the Kegel so that it's most effective. So to begin, I want everyone to kind of sit in an upright position and get comfortable. I want you to take a deep breath in through your nose and then exhale through your mouth. And with that exhale, I want you to squeeze those pelvic floor muscles. Imagine that you are trying to stop yourself from passing gas from the rectum and trying to stop the flow of urine coming from out of the bladder. You should feel a tightening and a squeezing in those pelvic floor muscles. We want you to hold that contraction for 3 to 5 seconds. This can be a little bit tricky initially, but keep practicing, because the majority of people who continue to practice this, they really get that Kegel squeeze down. We recommend 3 sets of 10 Kegels per day. And the nice part about Kegels is you can literally do them anywhere. So while you're sitting at a stoplight, while you're cooking dinner, while you're exercising. And this is really helpful, especially to have that flexibility as busy moms.
So another treatment option that we consistently use are pessaries, as Kelsey had mentioned before, for prolapse. Pessaries are devices that can be inserted into the vagina to treat stress incontinence or to support prolapse. Like we discussed, like a sports bra for the vagina, just keeping everything up and inside. Pessaries have been described throughout history as devices, like I said, to support the prolapse, starting in ancient Egypt, where they were first described, and then kind of moving through history as different materials that have been used to hold up and keep that vagina supported in the pelvic floor. So such as fruits like pomegranates or potatoes, we've heard, linens or other kind of hard fashioned materials such as hammered metals or rubber. And then down to today, where we are primarily using silicone, medical grade silicone that is in different shapes and sizes. So I wanted to give you two options that are on the market over the counter. These are both for stress incontinence. So stress incontinence is the leaking of urine with laughing, coughing, sneezing, jumping, or activities. So as Lisa said, the pelvic floor muscles are weak. The urethra is just not able to hold up against those abdominal pressures. So poison pressa or revive pessary are two of the ones that we most commonly talk about with patients in office. Again, over the counter. Poison pressa is over the counter for stress incontinence. It's a tampon-like device. It comes in 3 support sizes, and it can be worn for up to 8 hours like a tampon, and then you throw it away. With the revive pessary, again, supports the urethra with gentle pressure. This one is a silicone device that you can wear for up to 12 hours in a day and reuse for up to 31 times. So like a month of use for these. We also have pessaries that we fit in office that can be used either for prolapse or for stress incontinence, or a combination of the two. And you see some pictures of some common pessary kind of styles and shapes here. But these require what's called a fitting appointment after an initial assessment with us. Includes an individual teaching on placing and removing the device and cleaning the device as well. And these can be used for many years with proper cleaning and care.
And then the last thing that I wanted to mention is that, of course, this presentation gives a general overview and what's most common in the postpartum period, but there are a lot of treatments that we just don't have a lot of time to cover during this presentation and may not be the most applicable during the postpartum period. But if there's other options you're interested in exploring, or if you're having any of these symptoms, it's definitely worth talking to your OBGYN about maybe what these options would be. So for incontinence, we do have treatments for urge incontinence where you really have to go to the bathroom that are acupuncture-like, and this is called percutaneous tibial nerve stimulation. This is something that is not studied during pregnancy, so we don't do it on anyone who's pregnant. And it can be hard postpartum because it's a lot of appointments. It's something someone comes in once a week for 12 weeks, and then after that, you come in once a month for the maintenance therapies. And we usually do that for about a year. There are also oral medications that you can take that help kind of relax bladder spasms when you have urgency. But in general, there's not any good data on these medications when people are breastfeeding. So overall, it's something that you can maybe consider once you're done breastfeeding and once you're done childbearing, because there's also not much data with them during pregnancy. And there are also a whole bunch of different office and surgical procedures that can be done if conservative options just aren't working for you. In terms of pelvic organ prolapse, I did just want to mention, and I briefly touched on this previously, that surgery is an option, but it is not something that's done until you are 12 months after your delivery or you have stopped breastfeeding for 6 months. And whichever one of those is longer would be the time frame that we would go with. And a lot of these surgeries are very big pelvic reconstructions. So it's something that we do once you've finished carrying any pregnancies that you want to in your lifetime, because a lot of them do involve a hysterectomy where we actually take the uterus out. So once again, if you want to explore any of the treatments we talked about today or talk about additional treatments, it's definitely worth talking with either your OBGYN or your family practice provider to maybe get a referral to someone in urogynecology. And then this is just some information about our practices. We practice out of 3 locations currently, and we're growing and expanding and may have some more soon. So you can see us out of Aurora, Central Park, or down at Lone Tree, which is probably what's closest for most of you because it's probably about 10-15 minutes from the Highlands Ranch Hospital. And with that, I think we're ready to take any questions that anyone might have.
Yeah, if anybody has any questions, feel free unmuting yourself, or if you're more comfortable putting it in the chat, you're welcome to do that as well.
I have a
There was-
question. Oh, sorry.
No, you're okay. There was a question about a whole hand, and I think that may have been about
Oh, that was me
pelvic
too.
floor.
Yes, no, I
Okay.
apologize.
Yeah.
It's
No,
just
that's
two,
okay.
usually 1 or 2 fingers. So I apologize if I misspoke. So it's not a whole hand. That would be scary.
Okay, that was one of my questions I had put in the chat, and then I just have another one. I am 1 month postpartum right now, and I'm not having any like pelvic floor symptoms right now. But when I had the first week and a half, and I had never given birth before, my baby was only like 4 pounds because he came early. I felt a lot of heaviness within the first like week and a half, 2 weeks. And is that normal for it to come and then just go away, or is that something that might come back?
A great question. I feel like we have, and Kelsey had previously mentioned that it can take the vagina like 1 to 2 years to completely remodel. So a lot of patients, they do see improvement. So initially, there's a lot that happened to your pelvic floor during delivery. So, you can experience some of those sensations, but they can improve. It's not to say that they necessarily won't return, but like those strategies that we talked about, avoiding constipation, going to physical therapy, doing things like that can really help so that you maybe not experience those again in the future.
So does not everyone feel that heaviness? Because I was like freaking out about it when I left the hospital because I felt so uncomfortable. Like I just felt like everything was just so heavy, like very, very heavy. And it felt like it wasn't like painful, and it would be worse if I was actually sitting for a long period of time rather than standing.
Yeah, absolutely. I mean, everybody's different, but you're not out of the norm. That's actually very normal. You did a lot of very heavy, intense pushing. Did you have a vaginal delivery?
Yeah, but I
Okay.
didn't push that long, and
Mhm.
my baby wasn't that big, so I was just wondering if it was like,
Yeah, no, I mean, I had a little kiddo too with my first delivery, and I experienced the same sensations. So it's just the fact that you're, even it's similar to constipation. So you're still doing that pushing, which puts pressure on that pelvic floor. So as those muscles kind of recover from that delivery and from that trauma, even if the kiddo was really little, you can still experience those sensations. So, it is pretty common for people to start to feel better, as they are further out from that delivery.
got it. Okay. Well, should I still like consider pelvic floor, like seeing someone because I went through that, or should I just kind of like
Absolutely. Oh yeah.
wait
No,
and
I
see
encourage every postpartum mama, even if you're not having any symptoms, at
to do
least go
it?
for initial evaluation. It's very worth it. And they can give you a lot of tools in your toolbox to help if anything gets worse for you in the future.
Okay, so just ask my OB for like a referral then.
Yes,
Okay.
absolutely. Absolutely.
Okay, awesome. Thank you.
Of course.
We had another question come in. I can read it. Or where is the line of when intervention is necessary? I may have some minor signs of the overtoned, and I have some urinary urgency, which surprises me postpartum since I don't have a baby sitting on my bladder anymore. But I don't really have any incontinence. Is that something that will go away with time or more likely to get worse with future children?
I think that's a great question. So everything that we focus on in our practice is quality of life based. So if those symptoms are something that you're really thinking a lot about and it's bothersome, because a lot of times, you may not have access to the bathroom, like if you're in a mall and you're walking around, or if you're somewhere where you don't know where the bathroom is, that can be really bothersome. So if it's bothersome to you, it's definitely worth talking to someone about it, because then there's lots of different things you can do and try that may improve those symptoms. But overall, like if you notice that you have that urgency, but it's not something that's bothering you, then it's not necessarily something that you have to address. And just in terms of, can it get worse? Can it stay the same? Everyone's a little bit different. Some of my patients, as they get further and further postpartum, and as their estrogen levels start going up after they stop breastfeeding, they notice a really big improvement in some of those symptoms. And other times, when patients let those symptoms go on, they can get worse. So if it's something that you're concerned about and it's bothering you, I would talk with your OB. And a really great place to help with those symptoms is pelvic floor physical therapy.
Great. Any other questions?
Yes, I have a quick question. Are you are you guys taking appointments on the weekends?
None of our clinics are currently open on the weekends. We are currently open from 8 to 4:30, basically, with our last appointment being at 4 o'clock during the week.
Thank you.
But we are growing, we're expanding, we're adding 2 more docs here soon. So I won't say that that's not something we may offer in the future.
Any other questions? All right. Thank you guys so much for hosting this webinar. We appreciate it. Such good information. And if you guys do want to send me anything, I can get the information out to our registered mamas after the webinar as well.
Thank you so much for everyone for attending. We really appreciate it.
Yes, thank you, mamas. We appreciate your attendance. You guys have a wonderful day.
Bye, everyone.
Thank you guys so much. We
You're welcome.
appreciate you. Great info. Bye.